neoadjuvant chemotherapy in the very young breast cancer patients. Dr. Loibl.
Thank you, Dr. Arteaga. Good morning, ladies and gentlemen. I would like to introduce you to our presentation today, the neoadjuvant chemotherapy in the very young breast cancer patients. We looked at 8 neoadjuvant trials consisting of 8,949 patients, grouped them in 3 groups, younger or equal to 35 years of age, 36 to 50 years, and older than 50 years. We compared the PCR as well as the disease-free, local recurrence-free, and overall survival, overall and by subgroup defined by the hormone receptor and the HER2 status. This is the breast cancer subtypes according to age. As you can see in the upper panel, those 35 years of age and younger, a third have a triple-negative breast cancer, and about a third have a hormone receptor positive HER2-negative breast cancer. This changes by age. The older patients have less triple-negative tumors, but more hormone receptor positive and HER2-negative tumors, but there seems no real change in the HER2-positive breast cancer patients. The PCR rates overall and in subgroups are shown here. On the left, we have the overall PCR rate, and there is a significant difference between the groups. The youngest have the highest PCR rate with about 23.6%, going down to 13.5% in the group older than 50 years of age. If you look at the different subgroups, it's also a significant difference in the hormone receptor positive HER2-negative group, and on the far right side, the triple-negative group. The triple-negative very young breast cancer patients have a PCR rate of 35% with an anthracycline taxane-based neoadjuvant chemotherapy between 18 and 24 weeks. We adjusted this analysis, and it was an independent predictive factor age overall, and in these 2 mentioned subgroups, the triple-negative and the hormone receptor positive and HER2-negative group. We looked at the survival also in these patients, and we know that the non-PCR patients are driving the survival. We have seen the presentation from the FDA yesterday. On the left side, we have the disease-free survival, followed by the local recurrence-free survival and the overall survival. And there is a significant difference, an inferior survival for the very young women not achieving a PCR. They have a 25% higher risk of relapsing or having a local regional failure. The overall survival is not statistically significant different, but there is a trend towards an inferior survival also for the very young patients. This is, I think, one of the most important slides because we looked at the disease-free survival in the different subtypes by PCR and age. There were 6 groups, 3 age groups, and the PCR and non-PCR groups. And just look at the pattern of these slides. So there is a different survival pattern in the different subtypes. On the lower right side, we have the triple-negative group. The PCR patients do excellent, irrespective of age. The non-PCR patients don't. On the lower left, we have the hormone receptor negative but HER2 positive patients. This, again, the PCR patients do very well and the non-PCR patients don't. But there seems already a slight split between the age group. This is not statistically significant. On the upper left side, these are the hormone receptor positive HER2 negative patients. And as we heard yesterday, there is no, and we have presented that as well, there is no difference in the older patients between PCR and non-PCR in these luminal-like breast cancers, but the young women derive a benefit from a PCR, this is the purple curve, compared to the non-PCR very young women shown in blue. In conclusion, very young women are more likely to achieve a PCR after an anthracycline taxane-based neoadjuvant chemotherapy. And in contrast to other analyses, the very young women with a luminal-like tumor benefit from a PCR. We think that breast cancer, the very young, is biologically different, and young women with luminal-like tumor should be considered for neoadjuvant chemotherapy. Thank you very much.